Yes, we are
Yes,
live.
sir. We are.
Okay. Yes.
Yes.
So, very good evening, all. I just welcome all the participants here. I can understand, and I thanks to each and every participants for sparing your valuable time here. So, today we have a very important topic here, and your day-to-day routine, you see vertigo. So, we have a vertigo topic with both the prospective ENT as well as neuro prospective, and we are doing this event from Star Hospital, and we as a Johnson and Johnson are associating with Star Hospital for doing this event on vertigo. And we have two very eminent speakers from Star Hospitals, Dr. Srinivas Kishore. He is a consultant ENT and hand and neck surgeons at Star Hospital and specialist in snoring and sleep apnea. And doctor has done his MS ENT from Manipal University, and the doctor has got more than 20 years of experience in the field of ENT, and he has published many journals nationally and internationally. So there is a lot about doctor, but this is what a brief I have discussed about Dr. Srinivas Kishore. And we have our another speaker, Dr. Balraj Shekhar. So he is a consultant neurosurgeon at Star Hospital, and doctor has done his MS MCH neurosurgery from PGI Chandigarh, and doctor is having more than 10 years of experience in the field of neurology, and doctor has also has many journals on his name in nationally and internationally level. So this was a brief about our both the speakers, Dr. Srinivas Kishore and Dr. Balaraj Shekhar from Star Hospital. So we'll not take much time and we'll start. So very first I would like to invite Dr. Srinivas Kishore, who would be talking on vertigo as an ENT perspective. So, sir, please come on the dice and just start your presentation, sir.
Okay. Thank you very much, Narendra, for your kind words and your kind introduction. And I would like to thank Janssen division of Johnson & Johnson for this opportunity. And without further ado, let me just go ahead and share my screen and start my presentation. Okay, are you able to see my screen?
Yes, sir.
Yes, sir.
Okay. All right. Good evening, everybody. This evening, since you've decided to spend your time with us, and really appreciate that you're spending your valuable Friday night with us. Today, me and my neurosurgical colleague will sort of try to give you a balanced approach and management protocols in the management of vertigo. So vertigo, when the moment we speak about vertigo, people think it's a very difficult topic or it's a very confusing topic. Our field, I mean, our job today is basically to try and see if we can simplify it for you, because vertigo is very as complex as it sounds, but if you divide it and approach it in the right way, you can come to a diagnosis very easily, and management is not as complex as we think it is. So before going into the management per se, I would like to first start with a basic anatomy and physiology of this. So just to bring you pace to what is going on, I just want to describe a little bit about the anatomy and its relationship with the management of balance in the body. So as you all know, the inner ear has two main functions, which is balance and hearing. Now let's focus on balance per se. The balance, again, is divided into two kinds, two parts, which is the semicircular canals and the utricle and saccule. Now, the semicircular canals deals with angular motion, whereas the utricle and saccule, it basically speaks about linear motion. That means front to back, whereas semicircular canals deal with angular motion. Now, each one of us have two sets of three semicircular canals and two sets of of utricle and saccule, both of them giving information about where we are in space to the brain. Now the brain receives this information from both the inner ears. It combines the data that it receives from the eyes and the tactile inputs and the proprioceptive receptors. Then, based on the information that it already has in terms of memory, then it basically gives the input via the spinal cord to the muscles and also through the oculomotor system to the eyes to give you a perspective of balance. So if there is a problem in any of these basically, whether it is semicircular canal or saccule, or your brain understanding the input that's coming in, or if there is any input that's coming from the eyes or from the pupil, if there is any problem in any of these things that I've spoken about earlier, the brain would obviously get confused and a person would land up with vertigo. Now, it is very important for us to understand that because people speak about vertigo in very different terms, because not every person can describe their symptoms very clearly. Some of us would hear that a Google read person would come to you and say, "Doc, I have vertigo." Or a very old person might come, would also basically, because his grandson has told him that he has vertigo, he may say he may have vertigo. But first, it is up to us, the clinicians, to understand and decipher the symptom complex that they're describing. Now, for me, this is how I would understand it. I need to ask the patient, how is it that he actually feels? Does he feel that the whole world is spinning around him? If that is so, it's definitely vertigo. And the second question you should also ask is that, is the room spinning around him when he's sitting steady? Or is it only spinning around him when he is in motion? That's a very important thing, and the implications of this we will discuss a little further. The second thing that we need to understand is, do you feel unsteady? So if you feel unsteady, then it is not the classical vertigo, then it is actually disequilibrium. This is a symptom that is more common we see in the older age group people, or people with diabetes or peripheral neuropathy and things like that. The next question that you should ask is, do you feel like you're about to faint? Do you feel woozy? Do you feel blurred? Or do you feel that you're going to collapse? Or some people will just come and use the word and say, I'm just feeling dizzy. So if you ask them the question, what do you mean by dizzy? They don't have an answer. So if the patient confirms with one of the above symptoms, that if they say that I'm just dizzy and have nothing else to say about it, please bear in mind that they may have a condition which is not a psychiatric disorder. It's called phobic postural vertigo, which is a different diagnosis, and the management is very different. So it is very important that you elicit this particular understanding of their symptom. The other reasons why a person might feel dizzy is most of us would feel hypoglycemic after some time, while you're seeing a busy OPD, or there may be just sheer anemia that could be giving rise to this symptom. Medication, a lot of people take medication, whether SSRIs or tricyclic antidepressants or anxiolytics. They also can can cause problems in terms of balance. Anxiety, sheer anxiety. Nowadays, we're seeing a sudden explosion post-COVID of anxiety and a sudden drop in blood pressure. For various reasons, for whatever reason it might be, they may also complain of these particular symptoms. But the most important thing is that you need to try to understand the patient's symptom. Whatever they may say, you have to take it with a pinch of salt and try to extract more information. Now, this is exactly what I described as so you need to differentiate whether it's a vertigo, is it a disequilibrium, is it a pre-syncope, or is it just lightheadedness? some patients, after they are better, after an attack of vestibular neuronitis also, they continue to have this lightheadedness. So you need to differentiate between these forms of dizziness and just lightheadedness. So because the diagnosis is very important, and 70% of the diagnosis can be just got on history itself. Now, there are many ways in which you can arrive at a diagnosis once you're talking about vertigo. For us ENTs, we go based on whether you're going based on what are the associated symptoms or what is the duration, what are the other conditions that are associated with it, so on and so forth. So I'm going to briefly describe to you how do you arrive to a diagnosis, or how do you zero down on your diagnosis based on the symptoms that are associated with the primary complaint of vertigo. Now, supposing if the patient is having ear symptoms, supposing the patient says, I have ear discharge, or I have tinnitus, I have hearing loss, obviously anybody would think that it is associated with an inner ear problem. But for us ENTs or for general practitioners, if the patient says that there are visual disturbances, there are paresthesias, there is a headache associated with vertigo, whether at the same time of the vertigo or has history of migraine, you have to think of a CNS involvement. Most patients who have either CNS problems or a classical case of Meniere syndrome would have autonomic symptoms. A lot of our patients with Meniere's, who are classical Meniere's patients, do complain of increased sympathetic activity. They have increased bowel movements. In addition to having nausea and vomiting, they do have increased bowel movements and they rush to the toilet, or they have sweating, they have palpitation, all these things. These you should not be confusing with some kind of MI or a stroke. But if you think that, if you suspect that there is a possibility that a neurological problem could be there in this condition, elicit it through history and you'll be able to pick it up. Now, patients having visual and olfactory symptoms always think of a migraine, but then they should have a migraine history. The International Headache Society has clearly given guidelines on how you diagnose vertiginous migraine or migraine-associated vertigo. And of course, this is not the platform to discuss that. Now, here are a set of a list of symptoms that can be associated with vertigo. I'm not going to read out all of them, but very few of them pertaining to my subject. If a person has vertigo with facial weakness, definitely acoustic neuroma is something that you could think of, but also think of herpes zoster or Ramsay-Hunt syndrome. But in these patients, they would definitely have the classical descriptions of herpes, and they would have so much pain associated with this. So it's not, you cannot ignore that particular factor. Always think of, if there is tinnitus, definitely think of acute labyrinthitis. This last few months, we've had an explosion of acute labyrinthitis. If the patient is having tinnitus, along with hearing loss and dizziness, these three things are the diagnosis that you should think of. Acute labyrinthitis, which is common, but when you are making a diagnosis of acute labyrinthitis, there usually will be a viral prodrome. Acoustic or vestibular schwannoma is another condition, but you would have other associated symptoms. Meniere's disease, which is of course a clinical triad associated with vertigo, fullness in the ears, tinnitus, and progressive sensorineural hearing loss. Initially, they will have fluctuant hearing loss, but progressively it goes down. It is a lifelong disease. It is something that doesn't just come and disappear. So we will discuss a little about this further in the topic. So once you've come to a diagnosis based on the symptoms that are associated with the primary symptom of vertigo, here are other clues that you can elicit based on medical history. Like I said, history actually unlocks vertigo. If you can spend some time with a patient of vertigo, you can come to a diagnosis. So here are certain key questions that you need to ask your patient. So the first thing that you need to ask is, when the patient was describe your first attack. And the next question would be, what were you doing at that particular time? Were you doing anything? Were you just sitting, or were you doing something like an exercise? So if the patient can very clearly describe his or her attack, that would give us a lot of information about the diagnosis. One key factor that nails the diagnosis or takes you in the particular direction is whether it is rotatory vertigo, or it is non-rotatory vertigo, or unsteadiness, or is it disequilibrium. If the person says that the whole world was spinning around him, it's probably an inner ear pathology. The next question you need to ask is it constant, or does it come and go? If it is constant for hours together, it would indicate one thing, as opposed to if it is constant for days together, it would again lead you to another diagnosis. Now, another important question that you need to ask is, how was the patient in between the attacks? Was the patient absolutely fine between the attacks, or are there any residual symptoms in between the attacks? Then, how was each individual attack? Was it progressive in severity, or is it getting better? And of course, last but not the least, what are all the accompanying symptoms? If you actually ask these particular questions, the patient himself will give you the diagnosis. So these are all the questions that you should ask for. But one particular point that I would like to make is the use of medication. You know, a lot of us have patients with polypharmacy, especially the older age group. We call it polypharmacy. There are a bunch of about 15, 20 medications that these patients would be having. And it is prudent that we take their prescription, and they keep taking these medications without knowing, because if you say, they will have a bunch of files, and each one of them will have a few medication, each contradicting one another. So please elicit proper pharmacohistory to find out what all medication they are taking. Drugs like furosemide, antidepressant, antipsychotics, anticonvulsants can give rise to a symptom of not vertigo, but unsteadiness, dizziness, and things like that. So changes in head position, always ask for that. If the patient says that whenever I had changed my head, that there is an increase in symptom, definitely it is a peripheral vertigo, something to do with the vestibule, and you can go about evaluating the patient in that direction. This is something that I spoke about a little earlier. Now, assessment based on duration. This is a very, very important slide, and it is important that we spend some time assessing this. First, you have to make a decision whether these episodes of vertigo are come and go, also called as, are they episodic or are they prolonged? If they are episodic, how are they? Are they lasting for a few seconds? Do they last for a few minutes? Do they last for a few hours? Or do they last for days together? Now, if it is episodic and if it is only for a few seconds, definitely it is probably BPPV, or it probably is a labyrinthine fistula if the patient is having these symptoms when the patient is coughing or sneezing. Okay. If it is for hours, definitely if you're making a diagnosis of Meniere's disease, the duration of the symptoms should be at least for a few hours. Meniere's disease does not cause episodic vertigo which lasts for a few seconds. And patients with Meniere's disease are just incapacitated. They just have to sit down. They cannot do anything for that particular time. Now, the other symptom, the other history that you should elicit is prolonged vertigo, which is lasting for a few months. Especially vestibular neuronitis takes at least 6 weeks to completely recover. If the patient has had a history of head injury or an ear surgery wherein there was a cholesteatoma that has eroded the semicircular canals, obviously it takes time for the rehab to happen. So it is understood, and we have to counsel the patient that this unsteadiness is going to take a while for them to get better. Now, you should also consider and take history whether there are certain drugs that the patient is on, drugs like anticonvulsants that I spoke to you earlier about, that you should bring that, drugs like alcohol. A lot of patients come to us who are chronic alcoholics, who come to us and take sleeping pills for themselves because they don't feel sleepy. Of course, alcohol and sleep, they're actually they're antagonistic to each other, and they take medication to fall asleep further, and these things cause problems. Now, one particular disease that I would like to highlight at this point is vestibular neuronitis. Vestibular neuronitis is very common, more common than we actually think of. It is sudden on onset, is often associated with all the symptoms of vestibular failure. That means there will be nausea, there will be vomiting, and the nystagmus can be elicited towards the healthy ear. And this condition doesn't go away that easily. Also, the first attack of vertiginous migraine or migraine-associated vertigo can also cause this kind of symptom. But the first attack of Meniere's, if it is not associated with any kind of otologic symptoms, that means cochlear symptoms associated with this, you cannot make a diagnosis of Meniere's disease. Now, recurrent vertigo, Dr. Bala will speak in detail about that. Meniere's disease, like I said, is a lifelong condition. It's a condition that will burn out itself, always associated with fluctuant hearing loss initially, and then progressively there will be sensorineural hearing loss. And once the hearing loss goes off, and then the disease will stop bothering the patient. But there are many ways and means to take care of it. There are different stages at which you can intervene and manage this particular patient. Perilimb fistula is something that we very commonly see in our ENT practice. One particular simple sign that you can elicit is doing what is called as a tragal pump, the tragal sign. Then if you can just pump with the tragus, if the patient is having nystagmus, definitely there is a perilimb fistula. There are lots of investigations that you can do to rule that out, but very simply you can do this particular test to give the diagnosis away. Now, once you come to diagnosis, you cannot jump to an MRI or a CT immediately. You have to look in the patient's ear. Always try and elicit nystagmus, whether it is gaze-evoked nystagmus or look for spontaneous nystagmus. Even for us as ENTs, we should have do some basic neurological exam, try to look at the gait, try to check the cranial nerve function, and so on and so forth. Romberg's test and Dix-Hallpike is something that we have to do. Dix-Hallpike is something which will give the diagnosis away for BPPV. Once you make the diagnosis, then and there you can do the Apley's maneuver to sort out the problem, and these patients are forever thankful to you. Once you do once you're talking about diagnosis, one simple testing that you can do is caloric testing, which you can do in the clinic. It's very easy, and which will give away the diagnosis if there is vestibulopathy or no. It's very important that you differentiate between central and peripheral vertigo. Here is a chart. Very clearly you can make out these differences, whether it is central or peripheral. Always consider, if there is a central vertigo, the symptoms are much more severe, the patient is much more sicker, and there are no other signs of cochlear involvement. Maneuvers for BPPV, when in terms of management of peripheral vertigo, BPPV is something very easily managed. Pharmaceutical treatment, talk a few words about that, and rehab. It's very important that you elicit which canal is the problem, whether it is the lateral canal or it is the posterior canal. If it is lateral canal, you need to do a rollover test to make the diagnosis and do a Simon's maneuver. If it is posterior canal BPPV only, a APLES will work. Coming to pharmacotherapy, what are the goals of the pharmacotherapy? Your goals are, for whatever it is, whatever management it is, one, you need to eliminate the hallucination of motion because the patient is having acute symptoms. You want to reduce the neurocognitive and psychological effects that this particular symptom is causing. And you want to improve the compensation of the brain to take over the function of the paralyzed vestibule. How do you achieve that? You can achieve it through three modalities. You can have specific treatments. If you know the specific cause, you can give symptomatic treatment, and there are certain treatments that you can use for rehab. So how do these agents work? There are groups that work as vestibular suppressant. There are medications that work as antiemetics, and they are the versatile calcium channel antagonists. So when you have a diagnosis of Meniere's syndrome, based on the stage of the disease, you know, the American Academy of Otolaryngology has divided the Meniere's syndrome into three types. There are probable, definite, and certain. So based on the amount of hearing loss that has happened, you can divide them into stages 1, 2, 3, and 4. And the first is the medical management, wherein all these things come: dietary restrictions, diuretics, and all the medications. In stage 2, you can consider cochlear sparing intratympanic injections. Stage 3, you go in for surgical management, and stage 4 and 5, you go for debilitating procedures wherein you ablate the labyrinth. In migraine, there are beta blockers that you can start with. It is very important that you give the right dosage. Giving pediatric dosage and doses which are suboptimal will not yield results. Calcium channel blockers and tricyclic amines. Whenever you're giving these medications, please explain to the patients what the side effects of these can be. They appreciate that a lot. If there is a vestibular-basilar insufficiency, and if you think that you have no access to a neurologist immediately, you can give the patient a loading dose of aspirin and shift them to the necessary hospital for adequate management. Now, antihistamines are drugs that are very effective. Drugs like promethazine are very good in acute management, but they don't score very well in chronic use. Drugs like cinerazine, you can start off from 25 milligrams twice a day to thrice a day based on the need. Histamine analogs like beta-histine, these are the cinerazine and beta-histine are drugs that we use very commonly. A lot of people use these two things in common or in combination. There are some merits and demerits of using them in combination. We will talk about it a little later. When a patient is having an acute episode of any kind of vertigo, especially after vestibular neuronitis, it gives a lot of merit to add in drugs like lorazepam or diazepam, because they are psychologically very disturbed. So giving this would give a lot of soothing and the patient doesn't panic that much. Prochlorperazine, this is a drug that we use very, very commonly, but please remember that these are the drugs that you can use only during acute phase, and you cannot use it in for long-term use. Prochlorperazine has antidopaminergic effects and antiemetic effects, but these medicines can also come with a lot of side effects, so be careful if you want to use it for more than 3 to 5 days. Cinnarizine has mechanisms of action. It has the effect of calming the excited vestibular labyrinth. It also has an anti-vasoconstrictor activity, and it has it increases the flexibility of RBCs, allowing the RBCs to reach every nook and corner of the vascular compromised labyrinth, and that is how cinnarizine works. There are lots of clinical studies at various dosages, but personally, I think cinnarizine is very good, very gratifying, and always gives good results. Beta histine is something that we use a lot. The only contraindication is you need to be very careful when a patient is having peptic ulcers or bronchial asthma. Again, beta histine can be used at, they have a very wide therapeutic range, right from 8 milligrams, you can use up to 48 milligrams or about 90 milligrams. Well, we know a lot about beta histine, but one thing we don't know is how it actually works. It has an agonistic and antagonistic action. Finally, the important thing is it helps to reduce the endolymphatic pressure. So it can be used in Meniere's disease as well, along with cinnarizine. There is a fantastic combination that is nowadays available, which is cinnarizine and dimenhydrinate. Both work together in unison. Both cinnarizine and dimenhydrinate, but you should understand that this is not for long-term use, because again, if you give it, dimenhydrinate prevents central compensation, so you don't want that for a very long time. Cinnarizine can be given for a very long time, but dimenhydrinate should be given only for a short period of time. So, well, there are lots of clinical evidences that show that this combination works. Finally, for any kind of vertigo management, it is rehab exercises. You should encourage the patient to do these exercises and try to reduce acute vaporetin sedatives to the bare minimum till it is considered necessary, and put the patient on these rehab exercises. Drugs like cinnarizine can be used in combination with these beneficial exercises to help the brain adapt better. One needs to know when to refer, especially when there are cochlear symptoms that are associated, and then there is a lot of nausea and vomiting. It is best that it is referred to an ENT surgeon. If there are any kind of central symptoms, that is gait abnormalities or paresthesias or something like that, then you need to send the patient to a neurologist. It's important that timely intervention gives good results. In conclusion, one needs to differentiate whether a person is actually having a true vertigo, or is it some kind of a phobia that the patient is having. Make sure that the patient is having a peripheral vertigo or a central vertigo. Peripheral causes are quite common, but if you ignore a central cause, that could be very costly for us. Thank you very much. Let me stop sharing.
So, thank you, doctor. Thank you for your wonderful presentation.
Uh,
So, hope everybody might have got some value addition after your talk. So, we have our another speaker, Dr. Balraj. So, sir, I just would like to invite you. You can start your presentation. Sir, you are on mute, sir. You have to unmute yourself and you can start sharing your presentation.
Sir, I have sent a unmute request. Please accept it, sir. Sir, please unmute, sir. Balraj Shekhar, sir. Please unmute.
Bala, sir, you have to unmute yourself.
Bala, sir, I'm sending you unmute request. You please click OK, sir. Yeah, sir. Perfect. Go ahead, sir.
Hi, am I audible now?
Yes, sir.
Yeah, I'm Dr. Balraj Shekhar, and after a wonderful presentation by Dr. Srinivas Kishore, who is a very eminent ENT surgeon with us, and I think he has given a very good note of what is vertigo and how to go on with the vertigo and when to differentiate, peripheral causes from the central causes. And the main important thing, as was told by Dr. Srinivas Kishore in the last, the differentiation of peripheral vertigo from central vertigo is very important because you should not lose time, and especially in these days of endovascular interventions for stroke. So the hours lost are makes the disability permanent. So especially in the case of posterior fossa strokes. So if you can identify the central lesions and the central causes immediately and refer to a stroke center, endovascular interventions, endovascular thrombectomies, and at the same time thrombolysis can help a long way in preventing the permanent disability in these patients. Now with that note, I start my presentation. So first of all, what is vertigo? So the human balance is a very complex intervention, a very complex thing. There are many things which go into maintaining our posture. So the main important things, the receptors are obviously situated in the internal ear. So as Dr. Simas has told, they are utricle, saccule, and at the same time you have three semicircular canals which are paired on both the sides, and the inputs from here go into the central nervous system, and the integration is basically thought to be in the vestibular nuclei, and from there it is connected to various parts of the body like the spinal cord, the cerebral cortex, and the cerebellum. So all these play a role in maintaining our position in the space, static as well as in the movement. So what is this system? What is the control? Where is the control? So
Sir, please share your screen, sir. Please share your presentation.
it's not
We are
coming.
not able to see your presentation.
Wait 1 minute. It's not coming at all.
Yeah, yes, sir.
Linda,
You go to share screen, sir, in the down. One green button is there, share screen.
I'm screening. I'm sharing already.
Now stop and again share it,
It's
sir.
not
Yeah, yeah,
coming.
it started, sir, now. Yes, sir.
No, was I audible this all
Yes,
this
yeah,
long?
yeah, we can see it now, sir. You can start. You can continue, sir.
But I was
Please.
audible, na?
You were very much audible, sir.
Yeah.
Sure.
So what is the system of the balance in our body? As I told, peripheral system is the vestibular system. After that, the cerebellar, proprioceptive system, visual system, and basal ganglion system. These are the systems which maintain the balance in the body. So what is a vertigo? So any vertigo is basically thought to be because of two mechanisms, that is sensory mismatch and misinterpretation by the central nervous system. So any of these things or both of these things can result in a devastating thing for the patient, especially in not maintaining the balance, that is vertigo. Okay, so basically all the drugs as had been elicited and as had been told by Dr. Srinivas, many drugs are targeted towards histaminic receptors, which is the abundant neurotransmitter both in the central as well as the peripheral vestibular system. So if you come, so what is vestibular system? It is basically, I told you earlier also, it is a three semicircular canals which have crista ampullaris, and they have cupula, which is the vestibular which is the receptor for this movement, and that's angular acceleration. And horizontal canals especially are oriented towards the rotational acceleration. And the utricle and saccule have macula, which is again in otoliths. And these things, they have seen stereocilium and kinocilium, and the details of these things are not the purview of this presentation. So the movement, what I mean to say, the movement stimulates these receptors so that they start firing and send these impulses to the central nervous system, which because of which interprets the signals, and then because of the stored memory also retrieves the information and maintains the balance of the human beings. So the main coordinator of all these impulses which are received to the brain is the vestibular nuclear complex. There are 4 nuclei which are more important. That is the medial nucleus, lateral nucleus, superior and inferior nucleus. Among these, the most important thing to maintain balance is the lateral vestibular nucleus. So where are they located? They are located in the floor of the fourth ventricle, from the rostral medulla to the caudal pons. That's why, as the neurosurgeons and neurologists, you might be very frequently seeing that the tumors which grow in the posterior fossa region near the floor of the fourth ventricle, like medulloblastoma or ependymoma, all these things, they first present with the difficulties in maintaining balance only. So they may be vertigo-like symptoms, but they maintain with difficulty in maintaining the posture. So what medial vestibular nucleus mainly connects to the lateral semicircular ducts. The inputs are from the lateral semicircular ducts, and from there, they through medial longitudinal fasciculus, it goes to the external ocular muscles, and basically because of these connections, this nucleus controls the VOR, that is optic reflex. So superior vestibular nucleus, same, it is connected to medial longitudinal fasciculus to the external ocular muscles. And the lateral vestibular nucleus, as I was telling, it is the main thing, which is the main nucleus for controlling posture and balance. So the main efferent nucleus. So it receives inputs from all the semicircular canals, macula, vestibulocerebellum, and then it gives the efferents to the spinal cord. So through lateral cerebral spinal tract or spinocerebellar tract to maintain the tone, and it controls the vestibulospinal reflex. Next main important organ in this circuit is the cerebellum. The cerebellum is the regulator. It helps in the smooth functioning of the balance and the posture. So in this cerebellum, if we divide cerebellum into 3 parts, the main important cerebellum which is considered with the balance, which is concerned with the balance, is the vestibulocerebellum. It includes flocculonodular lobe and vermis. So the ipsilateral cerebellum, it receives inputs from the bilateral vestibular nucleus and connects to the ipsilateral vestibular nucleus in efferents, and from there to the fastigial nucleus, and the fastigial nucleus through the inferior cerebellar peduncle again connects to the bilateral vestibular nucleus. So in effect, the cerebellum receives inputs from both the vestibular nuclei, and it sends outputs to both the vestibular nuclei. So the cerebellum is the most important organ concerned with the balance and the equilibrium. So as we can see, the flocculus part controls the VOR, the nodular part also, and the superior vermis controls spinal reflex, vestibulospinal reflex. So if there is any problem or any infarct or any damage to the cerebellum, it causes hypermetric postural responses and poor adaptation to changes during standing as well as the step initiation. And that's why from these defects we can understand that the cerebellum controls the upright posture as well as the balance, both while locomotion as well as in the static position. So as we can see, this is about the flocculonodular lobe. The patients with the isolated flocculonodular lesions, they lose their ability to stand. Static equilibrium is also lost, and walk without swaying or falling, and tend to stall when sitting also with their eyes open. So even though the eyes are open, the cues are present, everything is intact, but there is no smooth functioning of this. So they will not be able to maintain balance even in the sitting position, standing position, as well as in the locomotion. So then is there any cortical center for this? So there is no specific designed cortical center known so far, but the cortex controls this postural responses by dentatorubral tracts and rubrothalamic tracts, and again thalamic getting back to cortex, and corticopontine and pontocerebellar pathways. And what is this VOR reflex, and what is how is it significant? So we'll see this, and it is the fastest reflex known so far, and it stabilizes the images of the object. during the head movement especially. So it functions like a semicircular canal sending to vestibular nuclei, and vestibular nuclei by the pathways which we discussed earlier through external ocular muscles, oculomotor muscles, and then maintaining the position. So it enables the conjugate eye turning in a direction opposite to the head movement. And this is very important because we'll later on see in this presentation what are saccadic movements, what is a nystagmus. So this is the thing. If any damage in this happens, how the brain compensates with saccade movements and all. So vestibulospinal reflex, and the main important tract for this reflex is the lateral vestibulospinal tract. So this vestibulospinal tract carries the impulses from the cerebellum, as we have seen earlier, and it helps in maintaining the posture. And when the lateral vestibulospinal tract is stimulated, it contracts the extensor muscles and axial muscles of the ipsilateral side and inhibiting the same muscles on opposite side so that the erect posture is maintained. And medial acceleration is detected by the medial vestibulospinal tract. So basal ganglion is also very important, has also very important role because we can see the balance abnormalities in the patients with the basal ganglion lesions like Parkinson disease. So it is mainly concerned with the memory of the balance. So storing and automatic execution of the motor movements and motor flexibility and adaptive behavior to the environmental changes, and somatosensory integration, muscle tone regulation, and control of the automatic postural responses. So all these things, all because of the control, all these function from the basal ganglion, we can see these abnormalities, various abnormalities like stooped posturing and inability to maintain the posture, flexion posturing, and all these things in patients with Parkinson disease. So what is oculomotor system and how is it important in maintaining balance? The first thing is the two principal tasks of the oculomotor system is the gaze shifting with the movements of your head and the gauge holding when the environment is moving and you still hold the gaze. So these are the two important functions of the oculomotor system, and it is carried out by mainly four things: saccadic movements, pursuits, vestibular, and vergence. The main important things are the saccades and pursuits. So what is saccadic system? The saccadic system rapidly brings images of interest onto the fovea of the eye so that there will be high resolution for the visual examination. So there can be spontaneous saccades, which are very commonly seen during REM sleep and all. Reflexive saccades, which we see in people when there is sudden sound, involuntary movement of the eye towards the sound, and volitional or intentional saccades. These have a specific purpose. And the saccadic control, the saccadic control is mainly in the brainstem as well as in the cortex, and the cortical areas are mainly prefrontal area, but there is no specific system which is found that this is the area from which the saccadic specific type of saccadic movements arise, but there are it is distributed widely throughout the brain. So there are some prefrontal cortex areas, posterior parietal cortex, hippocampus, anterior cingulate gyrus. At the same time, brainstem also. Brainstem is mainly capable of generating horizontal and vertical saccades, and subcortical areas like subthalamic nucleus, caudate nucleus, and thalamus and cerebellum. They are also involved in saccadic movements. So vertical and torsional voluntary saccades. So signal cerebrum, omnipause cells, this inhibit the burst cells, which initiate vertical and torsional saccades. The neural integrator for all vertical and torsional eye movements is in the interstitial nucleus of Kajal. It holds eye in the eccentric position, and by the burst cells achieved by the burst cells of MLF. So I'm not going in detail. This is not this out of the purview of this. And at the same time, pursuit movements. So as saccadic movements are in the involuntary control, the pursuit movements are always under the voluntary control. So it is different from the saccade movements in two ways. So hemisphere controls the ipsilateral pursuit movements, and PPRF and MLF are the burst centers. They are not involved. So this is mainly from the cortex. The pursuit movements are mainly from the cortex. So the nystagmus is defined as the rhythmic involuntary movement to and fro oscillations of the eyes. So there are many nystagmuses which I am confining myself to the nystagmus which is specific to the central nervous system. So they are the downbeat nystagmus, upbeat nystagmus, pure torsional nystagmus, periodic alternating nystagmus, and convergence retraction nystagmus. So if you see the downbeat nystagmus, is mainly seen in Arnold Cherry malformations. For a surgeon, is mainly seen in conditions with compressions like cervicomedullary junction compressions and all. That is Arnold Cherry malformation. So naturally, because of the domination of the horizontal semicircular canals, we have the eyes have the propensity to see a little upward. But uh, because of the disinhibition by the brain stem, especially cervicomedullary junctions, what happens is the movement shifts down, so that to compensate that, the brain starts nystagmus upward direction. So upward direction, sorry, the shift will be more towards the upwards, the nystagmus will be downwards. So this can be seen in conditions like paraneoplastic syndromes and Venix encephalopathy, cerebellar degenerations, and the drug overdoses, especially lithium, carbamazepine, etc. So the upbeat nystagmus, fast component beating upwards. So these occurs in the lesions of the medulla, and this is because of the interruption of the anterior semicircular pathways, just as we have been discussing earlier. So this is also seen in the medullary lesions and various brainstem lesions, cervicomedullary junction lesions. Also, we can see this. So the Bruns nystagmus is very important for a neurosurgeon, especially in the cerebellar Pontine angle tumors. So because of the slow growing extraaxial tumors, first they compress the vestibular nerve because they originate from the vestibular nerve, and gradually when they expand and compress the brainstem and the vestibular nucleus, the nystagmus pattern changes. So it is a combination of it is a basically primary position jerk nystagmus. So beating away from the side of the lesion and towards the lesion, if you see, it is lower, larger amplitude gauge evoked nystagmus. So it is mainly seen in acoustic neuromas. So what are the most common causes of the central vertigo? So the brainstem infarcts or transient ischemic attacks, posterior fossa tumors, multiple sclerosis, syringobulbia, Arnold Cherry malformations, and temporal lobe epilepsy and basilar migraine. So how to differentiate? So I think this was covered in earlier discussion also by Dr. Srinivas. So what are the conditions in both peripheral as well as the central vertigo according to the duration? So if it lasts for seconds, if it is a peripheral vertigo, it can be BPPV, but central causes are insufficiencies, which will vertebro-basilar insufficiencies. There can be TIAs or frank strokes, and minutes, again, it can be migraine or transient ischemic attack. If it lasts for hours, it can be seen in basilar migraine, but if it lasts for days, it can be vertebro-basilar stroke. And if it lasts for weeks or months, it can be again stroke, degenerations, and multiple sclerosis. So how to differentiate between peripheral nystagmus and central nystagmus by the findings? So if the nystagmus, direction of the nystagmus, if it is unidirectional, fast phase towards the normal ear and never reverses in direction, it is a peripheral vertigo. But in central vertigo, sometimes the nystagmus may change if the gauge is shifted towards the slow component. And the type of the nystagmus, uncommon to have a pure horizontal without torsal component. Always there will be a torsal component, and never purely torsal or vertical. But in central vertigo, it can be pure vertical, pure torsal also. The visual fixation, on the other hand, will eliminate the peripheral vertigo, but not the central vertigo. And other neurological signs, as we have been discussing, because there are so many systems involved with the control of the balance. So isolated lesions which cause vertigo is unusual in the central causes. So they can be brainstem symptoms, cerebellar symptoms, and basal ganglion symptoms, and various associated symptoms which are very common in the central vertigo, but they are not common in the peripheral vertigo. And postural instability is very severe in central vertigo, and the deafness is almost always absent in central vertigo. So what are the big five signs of the central vertigo? The skew, central fixation nystagmus, saccadic and pursuits, gauge evoked nystagmus, contralateral to spontaneous nystagmus, acute vertigo, and nystagmus with normal HIT. So other findings is in Romberg's position, false, and direction of nystagmus might change with the direction of the gaze. If the nystagmus is vertical or dissociated, it cannot be peripheral. And associated neurological signs like diplopia, dysarthria, dysphagia, numbness, depending on the part of the brainstem involved, this various presentations can be varied. So again, in this Halpack maneuver, what is the nystagmus if it helps in differentiating peripheral from the central vertigo? So the latent period of onset in peripheral will be 2 to 20 seconds. That's why if you remember, we Halpack maneuver, we wait for 20 seconds to see the vertigo. In central, almost it starts immediately, and the duration of the nystagmus is less than 1 minute with fatigability. But in the central causes, there is no fatigability, and the direction of nystagmus is unidirectional, usually a bit with torsional component, almost always with the torsional component. But in central, it may change with the direction of the head, and intensity of the vertigo normally will be very severe in peripheral lesions. In central, this may not be severe. So again, nystagmus, how will it help us to differentiate peripheral from central vertigo? The direction of the nystagmus, the fast phase away from the lesion, never reverses in direction. This is very important. But in central, it can reverse and it can change with the change in the position of the head. And in peripheral vertigo, as we discussed earlier, it will be horizontal with torsional component, but is never purely torsional or never purely vertical. In central, it can be anyways. And other neurological signs are often absent in peripheral lesions, and postural instability is more prominent in the central lesions. And visual fixation will not eliminate the vertigo in central causes, and deafness and tinnitus almost are always absent in the central vertigos. So this is a slide which depicts what have to be seen if a patient presents to you with vertigo, because the examination and history taking are the most important things for not wasting time if it is a central cause, and apt referral to other centers which can take care of more serious conditions. So this all visual acuity testing, dynamic visual acuity testing, visual field testing, pupil size and reactivity to see for any problem with UIM, eye motions we have to take in all directions, and eye movements, and vestibulo-ocular reflex has to be seen, and other cranial nerves have to be examined, and other cerebellar system and tone, muscle tone, and all. So complete neurological examination, quick complete neurological examination is mandatory in people presenting to us with vertigo. So these are some common conditions, common central conditions which present with vertigo in our clinical practice. The vestibular migraine is one common thing. So what is the mechanism for the vestibular migraine causing vertigo? This is basically because of the increased vascularity in the central nervous system, and increased vascularity causing cochlear and vestibular dysfunction, leading to vertigo. So it will have fluctuating dizziness and recurrent vertigo, both can coexist, and it is motion sensitive. Nausea will be there, and bilateral tinnitus can be present, but there will be no hearing loss. And eye soreness and heaviness, typical migraine symptoms can be their headache symptoms, like unilateral headache, or sometimes it can be bilateral also. So neck and shoulder tenderness and pain will be present. So again, various triggering factors can be of migraine can be seen in these people also. So anxiety, stress, caffeine related drinks, and all these things which were precipitate migraine can also be triggers for vestibular migraine or basilar migraine. So what are the diagnostic criteria? At least five episodes fulfilling the criteria. This is a current or past history of migraine with aura or without aura, and vestibular symptoms of moderate or severe intensity lasting between up to 72 hours, 5 minutes to 72 hours, and at least 50% of the episodes are associated with at least one of the following features of the migraine, like unilateral headache, pulsatile quality headache, and moderate or severe intensity aggravated by routine physical activity, and photophobia and visual aura. So what are the vestibular symptoms that can be considered as we have told here? So vestibular symptoms of moderate to severe intensity. What are the vestibular symptoms that can be included? So spontaneous vertigo, it can be internal vertigo or external vertigo, means a false sensation of self motion, or the sensation of the moving of the surroundings, motion of the surroundings, or positional vertigo, and visual induced vertigo, head motion induced vertigo, and head motion induced dizziness. All these things can be included in the vestibular symptoms associated with the vestibular migraine or basilar migraine. So again, the treatment is with we go by this thing, like depends on paracetamol, then NSAIDs and all. But we preferably are almost the somatriptans are contraindicated in basilar migraine, and we don't prefer to give triptans. That's why it's very important to to identify the vestibular migraine. It's not like normal migraine. Normal migraine is headache or normal vascular headache. So in basilar migraines, we prefer not to give triptans. Again, vertebrobasilar insufficiency. So it depends on the which part of the which artery, the basilar artery or the branch of the basilar artery is involved, or vertebral artery or the branches of the vertebral artery like pica, ica, or anterocerebral artery, and superior artery causing vertigo is little unusual. Other arteries like anterior inferior cerebral artery, basilar the branch of the basilar arteries, vertebral arteries like pica. So these are the main arteries which cause the symptoms, and depending upon the area of the brainstem damage, we get syndromes like lateral medullary syndrome, middle medullary syndrome, and cerebellar insufficiency, cerebellar symptoms and all. So if it is a TIA, there will be definitely waxing and waning of symptoms before he develops or he or she develops an overt stroke. So sudden embolic events may present with and they may present with dramatic presentations with vertigo and hemiparesis and pupillar abnormalities, oculomotor signs, and bulbar manifestations, especially because these innervate the brainstem. So it can be midbrain syndromes, pontine syndromes, medullary syndromes, and depending on the location. So again, what are the risk factors for basilar stroke? It is the same thing for any other stroke, like smoking, avoidable risk factors, non-modifiable and non-modifiable risk factors, lifestyle habits, hypertension, diabetes, which we all know. And the duration of the symptoms, maybe a few minutes. If it is a word stroke, it can be permanent. So the important thing is to identify the symptoms the symptoms may be due to stroke. So normally it is a habit of us to see vertigo, which is psychological. So it's nothing. So prescribe antihistaminics, which are widely available in the market, betahistine and all, and send them to home, and then ask them to come next day. So we'll be wasting a very golden period of saving the patient from permanent disability. So it's very important, as I have been stressing from the start of this presentation, it is very important to examine the patient thoroughly if he presents with vertigo, especially the vertigo is of the first time presentation, and if it is lasting for some period. So, and another thing which I want to stress in this presentation is the cervical vertigo. Because of this googling these days, many people, they complain of dizziness, whatever and all. They themselves tell the nomenclature of that symptom which they have, and they bring MRIs, X-rays, saying that I have cervical spondylosis, that's why I have vertigo. No, it's not the reason. The cervical canal stenosis causing vertigo, cervical canal stenosis as a main cause of vertigo is very rare, because the cervical canal stenosis, if it has to cause vertigo, it can be it should be very severe, leading to the deficient proprioception because of the dorsal column compression, or it can be because of the vertebral artery compression leading to vertebral artery insufficiency, leading to uh, vertigo. So it is very important, even though patient stresses on saying that I have cervical compression or cervical spondylosis, and that's why I'm having vertigo. So we have to examine thoroughly and don't go by MRIs. So, and as we have been discussing earlier, there can be various brain tumors, especially the tumors in the posterior fossa, and vestibular schwannomas, which can lead to imbalances and vertigo. So the treatment depends on what condition is causing the vertigo. The first important thing is to differentiate peripheral vertigo from the central vertigo. If it is central vertigo, is it a condition which needs to be attended upon on emergency basis, or it can be treated on outpatient basis? So this is very important to give a keen ear to what patient says and what we interpret by what we hear and what we see, both by inspection as well as by examination. Because the diagnosis starts from the time the patient enters into our OPD, by seeing the way he walks, by seeing if he's having any hemiparesis or more deviation. So our diagnosis starts, it does not finish, of course. It starts by seeing the time the patient comes to our OPD and listening to what he or his attendants say very keenly, and interpret the examination with the history findings. Thank you, and I conclude my presentation here.
So Thank you, doctor. Thank you very much for your wonderful presentation. So we can understand vertigo is like a very huge subject, but the way you have covered most of the points, I think that was quite easy. And so, sir, we have few questions, sir, which has come to me directly because some of doctor could not able to type in that question answer session. So the first question is there possible that some drugs that patient has taken or any other exogenic material makes temporary eye drops in inner ear? So hope Dr.
Yeah.
Srinivas, if you can
Yes.
answer this.
Yes. Bala, can you stop sharing
Yes, sir.
so that we can all come back to that view?
Yes, yes. Comment.
Just stop sharing. Yes, that's it. That's it. Yeah. Can you just give the question again, Narinder?
Yeah, I just read it. Is there possible that some drugs that patient has taken or any other exogenic material makes temporary eye drops in inner ear?
Yes. The commonest is salt and preservatives that most of us have in packaged foods. And most of the fried food that we buy outside is very high in salt. One would be surprised that even a bar of milk chocolate can have so much salt in it that a person might have disturbance in disturbance between the perilymph and endolymph and can cause ionic imbalance between the membranes and can have high drops and subsequently develop vertigo. So whenever we are treating a patient with Meniere's disease, we ask them to avoid salt, which is the most important sort of a food material, and also preservatives in packaged foods.
Thank you, sir.
I hope that, yeah.
So we have one more question. The question is, what is upper cervical chiropractic care and how can it help to treat BPPV?
Upper cervical chiropractic care. So
Yes.
this is something that I'm not aware of, but what I can tell you in terms of BPPV is BPPV is specific to the canal of its origin. So we need to treat it based on where its origins are, whether it is a lateral canal or it is the posterior canal. Posterior canal is the commonest, which can be identified by doing the Dix-Hallpike maneuver and treated by Apley's. If it is a lateral canal, you do the rollover test and do Simon's maneuver. These are very simple. And in the immediate post-op period, give some head end elevation for about 3 to 5 days. And this is usually gives very good results. But chiropractors in India, we don't have too many of them chiropractors. But nowadays, we are seeing people do that. But we do this ourselves.
So thank you, sir. Thank you very much. Next question we have, is there any non-pharmacological therapy for vertigo management?
Absolutely. I think most of the management is non-pharmaceutical. Um, the medicines are used are just to give symptomatic relief in the first few hours or few days after the onset. After that, we have to identify what is the root cause of the problem and hence treat it accordingly. And vestibular rehab is one of the most important things that we need to do. So it has to be rehab, rehab, rehab.
So thank you, sir. And the
Thank
next
you.
question we have, stress can also cause vertigo, and if it is so, how do you treat?
Stress.
Yeah, stress.
I think Bala can answer that.
Psychological, that's why, sir, if you can not identify any of these things, we talked in detail about peripheral and central vertigo. If you're not able to identify any of these reasons, the most common case is psychological vertigo. So because of lack of sleep and all, we see many people these days hanging before the system for late hours in the night, and they present with the vestibular migraine and as well as pure vertigo also. So So these stress relieving, stress relief medication and antidepressants help vertigo in many people. Yes, stress has a role in vertigo. It definitely causes vertigo, and antidepressants and antipsychotics in few, and mild sedatives can help. As I think, sir, Srinivas, sir, you have presented this in your presentation also. The mild sedatives like
Yes.
midazolam and all that sometimes eliminate vertigo in few people.
So there is a condition called phobic postural vertigo that even after they get better from their primary problem, the they cannot get away from that sense of unsteadiness or disequilibrium. We need to differentiate it from an acute case of vertigo, which needs to be treated aggressively, whereas this requires a lot of CBT.
Thank you, sir. Thank you
Thank
very
you.
much.
Thank you.
We have few more questions which are there in the YouTube.
Yeah.
Which drug is effective in chronic vertigo and duration of treatment?
Bala, would you like to take that?
Shall I, shall I
Yes.
answer this, sir?
Yeah,
Yeah,
you can
please
take.
go ahead.
First of all, Narendra, has been stressed by Dr. Srinivas. No, drugs should not be a permanent treatment, and it should not be a treatment for chronic vertigo. The chronic vertigo should be treated by rehabilitation. So you have to understand the cause why vertigo is happening. First of all, is it peripheral or central? And if you identify the cause, the vestibular rehabilitation is the mainstay of the treatment for chronic vertigo. And if it is associated with any psychiatric conditions also, they have to be treated aptly. And taking medication for long is not chronically is not going to address the issue of vertigo. This is a common thing which happens with many people. They simply use the drugs for some time, they get rid of vertigo, they stop using medication, they come again with vertigo, saying that your medicine is not working. If you ask the history, they say that we were okay when we were using medication. After that, it came back again because it is bound to come back, because we know what is the mechanism of action of antivertigo medication which we use at present. So the mainstay of the treatment for chronic vertigo should be rehabilitation, not the pharmacological treatment. So I think Dr. Srinivas agrees with me.
Yeah.
Thank you, sir. Thank you very much. So one more question is there. Thanks, doctor, for your talk. And what are major differences from peripheral vertigo to central vertigo? I think you have covered,
Yeah.
briefly that, but still, if at all you can sum up one or two line in this.
So, if you really look at it from a practice point of view, like a take home message, um, if you're talking about peripheral vertigo, the patient is definitely not very sick. Okay, I'm talking about vestibulopathies, whether it is Meniere's or it is usually it is not associated with any kind of symptoms like gait problems, paresthesias, hallucinations. All these very classical kind of symptoms are not seen in peripheral vertigo. Peripheral vertigo, definitely the patient will have symptoms which are either cochlear in origin or vestibular in origin or vestibular cochlear in origin. Try to elicit that history and those findings. And if there are any other symptoms which are outside this particular box of symptoms, think of central.
So thank you, doctor. Thank you very
Thank
much.
you
I
very
think
much.
we had this many questions.
Thank
So
you.
anybody else who has any questions from the participant, please you can ask. So no, sir, we do not have any more questions. So, sir, we will come to the end for this beautiful presentation. So, very
Thank you.
first, I should say thanks to all my participants for making, sparing their, precious evening, that on a Friday evening, and making this event as a big successful. And I say thanks to the Star Hospital for organizing such a, educational program for all the, audience. And we as a Johnson and Johnson, it will be our privilege always to support such educational webinar and programs. So, and thank you my both the speakers, Dr. Balraj Sekhar, Dr. Srinivas Kishore, for narrating wonderful on this vertigo. I think this was a complete package when it comes to vertigo. So thank you, doctor. Thank you once again for sparing your precious time and having a very busy schedule. Thanks a lot, sir.
Thank you very much, Narendra. Thank you very much, Naveen.
Yes. Lokesh.
And of course, Lokesh. Without him, we wouldn't have been able to do this.
Yes. Yes.
And thank you, Johnson & Johnson, again for supporting this wonderful initiative and calling both of us to this very nice program. Thank you very much.
Thank you, doctor. Thank you very much, sir.
Thank you.
Okay, sir.
Good
I'm
night.
just ending the meeting,
Thank
sir.
you, Narendra. Thank you, Naveen. Lokesh.